The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics.
Hello, everybody, and welcome back to the FlightBridgeED MDcast. I'm your host. My name's Mike Lauria. I'm an emergency EMS and critical care physician with a particular interest in critical care transport and an active flight physician. Today, we're continuing our series on respiratory support for the critically ill patients. So our series, Every Breath They Take. Last time, we talked about the Tao of non-invasive ventilation. And today we're going to talk about non-invasive positive pressure ventilation. So specifically the jiu-jitsu of CPAP and BiPAP, another topic that's near and dear to my heart in the ICU and critical care transport. So I specifically chose the title and really like the analogy of specifically using the word jiu-jitsu in this particular instance. In Japanese, it means the gentle art, and it's essentially close quarters combat and a lot of grappling techniques. So it's a lot of patience and movement toward positions of control and about understanding body mechanics and momentum and how the body moves and a bunch of other things. But it's this idea of slowly tweaking things and moving with patience, which is how I think we end up messing around with both non-invasive ventilation and the ventilator. Is using our understanding of the ventilator and human physiology to kind of tweak things and manipulate things to optimize how we support someone's respiration. And I think the overarching principles in my mind in critical care transport for CPAP and BiPAP are essentially a few things. First, I think that our critical care transport specialists, whether you're a physician, respiratory therapist, nurse, paramedic, whatever, at this level, we have enough we have the intelligence and the capability to understand on a much deeper level patient pathophysiology and when and how to use and titrate positive pressure ventilation. Non-invasive positive pressure ventilation. It's not just you turn it on, you set a PEEP, you turn the FiO2 to 100% and make sure their SAT stays above 90. That is Bush League. That we are way beyond that at this point. And especially with ventilators like the newer models that are coming out for transport ventilators, the Hamilton T1, etc. They have the ability to monitor and manipulate these settings, and we really should understand how to do that. The second principle, kind of coming off or building on that concept, is the fact that you can't just set it and forget it. These are not just things that you put in a PEEP, you set up pressure support for bi-level, you turn the FiO2 to 100, and as long as their SATs are okay, they're fine. You really have to continually reevaluate your patient, and it's more than just the oxygen saturation. And we as transport professionals should be paying close attention to that and have the ability to or maintain the ability to continually reassess not just the SAT, but how our patient is breathing, their respiratory mechanics, and are we doing a really good job of supporting them? And finally, titrating it. We should be able to or know how to titrate CPAP and BiPAP to optimize the support that our patients get, because it's really about that optimizing that support. That is how we reduce mortality, morbidity, prevent intubations, and really help our patients, not just slapping the thing on their face and putting in some initial rudimentary settings. So that said, let's talk about some of the settings. So if you're really interested in this and want a really good graphic representation and a really good explanation of some of the nuances of some of these settings, definitely go onto the FlightBridgeED website, check out Eric's talk or series of presentations on the art of mechanical ventilation, where it goes over this stuff really, really well. But for CPAP and BiPAP, essentially a couple things. First, the PEEP or EPAP, right? That's pretty self-explanatory. The FiO2, pretty self-explanatory. On the Hamilton and newer ventilators, remember that we're setting additive pressure support. So the Hamilton is additive. In that sense, I'm saying that you set the pressure support, and that is the pressure support above the EPAP or PEEP. And when we're initially setting up the ventilator, I think it's reasonable to actually start at a PEEP of 5 to 8. Yes, if they're profoundly hypoxic, okay, go ahead, start them out in an FiO2 of 100, but titrate it down quickly to what they need. And when you're setting the pressure support, shoot for a tidal volume returned, so an exhaled tidal volume that will give you roughly what you would kind of set in the ventilator, somewhere in the 6 to 8 cc's per kilo region. That's a reasonable exhale tidal volume, and it's probably a reasonable place to start. Those I think we're relatively familiar with. Other things that we should be aware of, handful of things. First, the rise time or ramp. So this is how quickly it takes the ventilator to hit that pressure support target, or that pressure support target over PEEP. In other words, the total IPAP. PEEP plus pressure support equals the total inspiratory positive airway pressure. That is your target. That's what you're telling the ventilator to do. And the rise time or ramp is essentially saying how fast you're going to get there. It's telling the ventilator how fast you're going to get there. And I think it's reasonable. Usually, I think the default setting on the Hamilton, for example, is like 200 milliseconds. The Hamilton will limit it, I believe, to somewhere on the order of like a quarter to a third of the total inspiratory time. In starting out around 200 is probably reasonable, but understanding that if someone's very air hungry, you can cut that time down a little bit. The sensitivity or the trigger. So I think the default setting on the Hamilton is about 5. You can go down as low as, I want to say, like 2 or 3. And you can go up, I believe, north of 15 or 20 or something like that. I generally don't ever go up that high. Remember that it's a flow trigger. So the Hamilton is sensing flow of gas through the circuit. And as soon as the patient goes to start to take a breath, it pulls some of that flow out of the circuit. So the Hamilton actually senses there's X many liters of flow going out to the patient, and X many liters comes back to the ventilator. And if it senses a difference of whatever you set the flow trigger at, 3, 4, 5 or more, then it says, aha, this person is trying to take a breath, and it delivers the breath to them. So starting out at like 5, and generally speaking, if they're really having difficulty triggering it, you could decrease that a little bit. Totally reasonable, especially for someone who's got a lot of air trapping, has a really hyperinflated chest, a very flat diaphragm. Sometimes it's really hard for them to initiate a breath. And so you may have to go down a little bit on the flow trigger to help them out. In transport, however, sometimes on a really bumpy helicopter ride, or especially like if you're on a road, going down a road, hitting tons of potholes, and the ventilator is sensing changes in flow, because not necessarily because the patient's trying to trigger a breath, but because of other things in the environment, you may actually have to go up a little bit on that flow trigger, because otherwise it's delivering pressure when the patient may not want it after going over some pothole in the road. That can be pretty uncomfortable. It could lead to dysynchrony, could lead to them swallowing air and getting gastric insufflation, and those things are kind of bad. So the sensitivity trigger, remember that. And then finally, the expiratory trigger, or ETS, or sometimes it's called flow termination. I believe in the Hamilton, it's ETS. And that is basically telling the ventilator when to stop delivering positive pressure. If you think about it, as you take a deep breath in and your lungs fill up with air, the flow from the ventilator to your lungs starts to go down. And essentially what the expiratory trigger is doing is it's telling the ventilator when to stop delivering the breath based on peak inspiratory flow, or essentially a percentage of that peak inspiratory flow. So the ventilator sees what the peak flow is going into your lungs. And as that tapers off, as your lungs fill up, you tell it to stop the breath at 25% of that peak flow, 50% of that peak flow, 75% of that peak flow. The lower the number, the longer the patient will get positive pressure support and the breath will be drawn out. If you tell it to cut the breath at 50% peak flow, the patient will take a deep breath in, and at 50% of that flow, it'll give them a shorter time that they're actually getting supported. So as the percentage goes up, the time that the breath is actually delivered to the patient goes down, and they have more time to exhale, but they have less time overall getting that breath delivered to them, if that makes sense. So to review, you get the PEEP or the EPAP, you get the FiO2, you have the pressure support above PEEP, the rise time or ramp, number 4. Number 5 is a sensitivity trigger. And number 6 is the expiratory trigger. Now, if you want to put this in the context of how we train residents and sort of the classic approach to mechanical ventilation, remember there are essentially 3 pieces of the puzzle: the trigger, the target, and the cycle, right? That is the trigger telling the ventilator when to give the breath, when to start giving the breath. The target, how to give that breath and to what point to give that breath. In other words, the goal, the target, what you're telling the ventilator to give. And then the cycle, we're telling the ventilator when to stop giving the breath, when to stop supporting them. And if we put all those variables in this context, the trigger is essentially, it's patient triggered, and it's triggered when the patient is actually able to pull flow out of the circuit up to the point that you set the sensitivity trigger. That is what's telling the ventilator, hey, give them the positive pressure support that I'm telling you to give. The target is essentially, you can think of that as the rise time, how fast to get there, and then the PEEP plus the pressure support, the total inspiratory positive airway pressure. That is the target. And then the cycle is essentially when you're telling the ventilator, chill out, to relax, to stop giving them the breath. And that is the expiratory trigger or the expiratory time sensitivity. And that is that percentage of the peak flow that you're telling the ventilator when the patient starts slowing the flow down, when their lungs start to fill up, what percentage of that peak flow to cut the breath off at. Okay, so those are some of the settings. I do also kind of want to dive into this because, not everybody who's hypoxic needs positive pressure ventilation or non-invasive positive pressure ventilation. There are other modes. I talked about this in the Tao of non-invasive ventilation. I want to really hammer this home that we should be selecting the way that we support someone's respiratory effort in critical illness and supporting their ability to oxygenate and ventilate based on the underlying pathophysiology, if at all possible. Sometimes we don't know, but a lot of the time we can figure it out. And that is the way, as clinicians, we should be selecting the mode and titrating the mode of respiratory support. So let's talk about what patients really, where's there good data and what patients really benefit from non-invasive positive pressure. So CPAP and BiPAP particularly. Number 1, COPD with acute hypercapnic respiratory failure. So essentially, when you are putting them on bi-level, right? When you're putting them, I shouldn't say bi-level, so BiPAP or giving them a PEEP plus a pressure support, that is augmenting their ability to increase their minute ventilation, because every breath they take, they're given some pressure support. They take a bigger breath, they exhale, their minute ventilation goes up. Minute ventilation goes up, CO2 starts to come down. You're treating their respiratory acidosis. Furthermore, you're decreasing their work of breathing and respiratory muscle unloading. Very interesting stuff on this, looking at how the respiratory muscles get to relax, how it actually decreases work of breathing for patients, especially with our COPDers who may be hyperinflated. Remember when they have that barrel chest and you could look at that X-ray and their diaphragm is essentially flat. Their lungs are huge. That causes mechanical problems with respiratory distress. or it causes mechanical problems trying to breathe when you're in respiratory distress in particular. When the diaphragm is flat like that, it changes the respiratory mechanics and it's hard to generate inspiratory flow. Using positive pressure, specifically BiPAP, under these situations helps their work of breathing. It helps them initiate the breath. It helps them trigger and take a deeper breath. PEEP, interestingly enough, in this case, so the overall positive pressure, the EPAP, the PEEP, may be very helpful because it actually counteracts the intrinsic PEEP and may actually reduce the isometric workload needed to generate flow. So that goes back to the kind of the same thing that I was saying. It's related to that work of breathing thing in the sense that when people are super hyperinflated, the workload needed to actually initiate the breath, aside from that flattening of the diaphragm phenomenon, is much higher. And therefore, by giving them PEEP, it, quote unquote, stints that airway open and allows them to decrease the isometric workload needed to just start the breath and generate that flow. So, both the PEEP and the pressure support are super helpful for those patients. And there's pretty good evidence for it in COPD exacerbations with acute hypercapnic respiratory failure. BiPAP decreases mortality. The odds ratio of dying has been reported as about 0.63, and that is very significant. If you actually look at the absolute risk reduction and calculate the number needed to treat a patient with a COPD exacerbation and acute hypercapnic respiratory failure and save their life, the number needed to treat is about 12. It also decreases intubations, which is very important for some of these patients. Avoiding intubation is a very, very significant patient-centered outcome. And the odds ratio of requiring intubation with positive pressure, BiPAP specifically, is about 0.41. So a reduction in the odds that you'll need to be intubated if you put someone on BiPAP. That is huge. Okay, number 2. Cardiogenic pulmonary edema. Our numbers in the ED in particular for residents, but because of BiPAP and CPAP, our numbers for intubating COPDers and patients in CHF with pulmonary edema have gone down substantially. And that's a good thing overall for the patient population. But cardiogenic pulmonary edema is another pathology where there is strong evidence, I would say, that it is very helpful at improving patient-centered outcomes. It's interesting because I was always taught as a paramedic that it stents open your airways, it opens up your airways, and it pushes the fluid out of the alveoli. Well, as it turns out, I kind of held that belief even through residency until I really started digging into it, and that's probably not the case. It's probably physically impossible for that level of pressure to actually push a fluid, a non-compressible fluid, in between the tight junctions of the alveoli back into the vasculature and then back into the bloodstream and returning it to the left side of the heart. That's probably not a thing. But the mechanics are very, very interesting, and you should be aware of this. Understanding this physiology is super important. We're pretty sure it does, and there's some interesting physiological studies that show this, is it decreases preload on the RV. So if you just increase the mean airway pressure, the pressure in the chest, it decreases flow from the IVC and the SVC into the right side of the heart. It's essentially slowing down or reducing the traffic jam from the right side of the heart through the lungs. So it's kind of like, pinching off the hose and reducing the amount of blood flow to the right heart. There is a relative reduction in afterload on the left ventricle. Imagine you have this struggling left ventricle and it's trying really hard to squeeze blood out and eject it into or past the aortic valve, into the aorta and into the extrathoracic aorta and all throughout the body, right? If you increase the pressure in the chest all around that left ventricle, what you get is it sort of helps the ventricle squeeze. And it kind of helps the ventricle squeeze with a relative reduction compared to the aorta outside of the chest, in the neck, in the brain, in the arms, in the abdomen. when you pressurize the thorax, you're actually decreasing that relative afterload and helping the ventricle eject blood out to the rest of the body, if that makes sense. It'll help, yes, it will actually help recruit lung units, and it'll increase lung volumes, and it will also decrease work of breathing, which is actually important in this case because if the underlying pathophysiology is congestive heart failure, reducing the oxygen demand of the respiratory muscles can actually be very important under these circumstances. So various ways that it's working and helpful. And yes, again, excellent evidence under these circumstances that it is in fact helpful. We have multiple Cochrane reviews, we have multiple systematic meta-analyses and systematic reviews, including Cochrane reviews that show that it is both that CPAP and BiPAP under these settings can actually reduce mortality, reduce intubations, and even reduce ICU stay under certain circumstances. Now, the question always comes up, well, what's better, CPAP or BiPAP for these patients? As it turns out, and this has been studied, there is really no difference between the two. They both seem to, again, reduce mortality and reduce intubations, and both seem to have similar reductions or effects on mortality in the sense that the number needed to treat is about 14, I believe, for both. But several studies have showed there's no benefit or no advantage of one over the other. That said, I will often generally still give them a little bit of inspiratory pressure. The most important thing is increasing mean airway pressure, but I'll still give them a little bit of inspiratory support and still use BiPAP. It's not dangerous, or they're not worse outcomes with BiPAP. Asthma is always something that comes up. The literature here is actually probably pretty mixed. Yes, it may reduce the work of breathing and offset the respiratory muscle, the inefficiency in the respiratory muscles. So it may help with work of breathing. And physiological studies do show reduction in the work of the respiratory muscles when you put a very critically ill asthmatic on CPAP or BiPAP. But there's no clear benefit to mortality. There's no evidence of reduction in intubation or ICU stay or anything like that. However, this may be because the numbers are generally super, super low. These days, we have really good treatments for asthma. I can count on one hand in the past 3 or 4 years that I've had a really, really sick asthmatic that we've had to actually intubate and had in the ICU that couldn't get turned around in the ED. And I can't even remember the last time I flew a patient with a really, really bad asthma exacerbation. Maybe my bias, it also may be regionally where we are in the country, but point being that the numbers are relatively small probably, which may affect the ability to detect a difference or an outcome difference. That said, do I still use non-invasive positive pressure for asthmatics? Yes, mainly because a couple things. One, if they can tolerate it, it's a great way to deliver continuous nebulizers or the nebulized treatments that they need and make sure most of it is actually getting down to where it needs to be in those bronchioles. Two, there is some evidence, like I said, that it helps decrease work of breathing. And I've seen this when they get on some positive pressure support, they start to calm down. They're able to take some breaths. If you manipulate things correctly, they can actually exhale appropriately. And so I think it helps on a number of levels. I would say the risk is relatively low. The benefit is marginal, but I will also say that intubating a really sick asthmatic is not a trivial thing, and managing them on the ventilator is also not trivial as well. It can be very complicated. So I think the benefit way outweighs the risk, and they'll still do it, even though there's no super strong evidence for it. And there's other beneficial pathologies. These are sort of less common things. I will point out that for viral pneumonia, COVID, and basically the whole hodgepodge of acute hypoxic respiratory failure from other stuff, when you're like, I don't know what's going on, they're just really hypoxemic, is really mixed. And you should consider things like for pneumonia, even though there's some signal in the literature that it may be helpful, overall, I would try other things first, specifically high flow nasal cannulas or other modalities that have actually demonstrated a little bit more benefit, perhaps in some studies, benefits over CPAP and BiPAP, and allows them to cough, take their medicines, talk to you, sleep, all those other things that are much harder with like a full face mask, BiPAP and CPAP. It helps actually, for some patients in the ICU, it actually helps prevent pneumonia. So especially in a whole slew of different post-op patients, helps them take nice big breaths, keeps their lungs open, offsets their work of breathing. And in trauma as well, people with rib fractures, especially older patients who they get rib fractures and then they're splinting, they can't take deep breaths, they're sitting in a hospital bed, they develop pneumonia. That's really, really bad and really, really morbid. So positive pressure can be helpful under those settings. Not saying you should put acute patients with acute traumatic injuries on BiPAP or CPAP, but just so you're aware. And then post-extubation, so in the ICU in particular, can help prevent reintubation. Anyway, the main things I think are acute hypoxic respiratory failure, the whole hodgepodge, asthma, CHF, and COPD. Now, there are a couple of other things that I forgot to add to that list, like neuromuscular disease. So like ALS, myasthenia gravis, Guillain-Barré, people where they're just very weak. Their respiratory muscles are weak. This can, under some circumstances, help bridge you to other therapies. And then OHS and OSA. So not the strongest data in the critical care world or the critical care transport world, but absolutely, if you have someone who you're transporting who maybe is struggling to breathe because they have an infection other than their lungs, or they're on CPAP or BiPAP at home anyway, those patients would be fantastic patients to support with positive pressure ventilation. Now, I think two of the main reasons that we should understand patients get put on, and the best evidence, is COPD and CHF. And I kind of lump those into two categories of non-invasive positive pressure support for obstructive disease, specifically COPD, and you can kind of throw asthma in there too, or congestive pathology. So specifically blood and fluid congestion in the lungs from a poorly functioning left ventricle. So obstructive and congestive. And to give credit where credit is due, I kind of stole this from several of my mentors, and in particular, Josh Farkas from the PulmCrit blog actually talks about this as well. There is no super strong evidence to support that this is better than other mechanisms, but I think it helps me and gives me a good mental model when I'm retrieving patients, when I'm on the helicopter plane, and when I'm in the ICU and the ED. So obstructive, the whole goal here is to optimize their pressure support and increase their minute ventilation, right? Because they have acute hypercapnic respiratory failure. So with these patients, I will keep the EPAP, keep the PEEP the same, and I will just titrate the pressure support up. So generally start at like 5 or 8 of PEEP, and then starting with pressure support of 5, then going up to 7, then going up to 9. So the total inspiratory pressure goes from, say, like a PEEP of 5, or let's just say 8. So the PEEP stays at 8, and when the pressure support goes up to 5, the total inspiratory pressure goes up to 13. And then if they're still struggling to breathe, they're still hypercapnic, they still need more minute ventilation, increase that pressure support to 7. So their total inspiratory positive airway pressure goes up to 15, and then go up to the pressure support of 9. Then that total pressure goes up to 17. The whole point is that delta P, that pressure support above PEEP, is increasing, giving them bigger breaths. Bigger breaths equals more minute ventilation, and that is what's getting rid of the carbon dioxide. So that is how I titrate for obstructive pathology. For congestive pathology, right? Remember we said the mechanism, the way that CPAP and BiPAP work is really just increasing that mean airway pressure, increasing the mean average pressure in the chest, decreasing blood flow coming into the right heart and congesting the lungs, and helping blood get out of the left side of the heart with that relative reduction in afterload. And so the whole idea here is to just slowly go up on the mean pressure. 2 ways you can do that. Just put them in CPAP and go up 2 to 3 centimeters of water at a time. Or if I am using BiPAP, I will just keep the pressure support the same. So I will do a PEEP of 8 with a pressure support of 2, and then we'll just keep on going up on the PEEP. PEEP of 10, PEEP of 12, PEEP of 14, so on and so forth. And so what's happening is the IPAP, the total inspiratory positive airway pressure, if you have a PEEP of 8 and a pressure support of 2, the IPAP will be 10. If I increase my PEEP to 10 and keep that pressure support solid or steady at 2, it'll go to 12, the total inspiratory pressure, the total inspiratory positive airway pressure. And so it goes up in tandem. You keep the pressure support the same, and you just start increasing the PEEP. And what that's going to do is increase the total or the mean airway pressure and support the heart that way. Okay. So let's go back to that COPD, because it's a very common pathology, common patient population end up using this for. Remember, there are those other settings that we can tweak. So, for example, that expiratory time sensitivity, that flow termination. Well, if someone needs more time to exhale on non-invasive ventilation, right? If they were on a ventilator, the classic FPC and CFRN answer choices, well, you have to increase the I to E ratio to allow them more time to exhale. Simplest way to do that is go down the breaths per minute. When they're not on mechanical ventilation and not intubated, right, and they're not sedated, then you can't necessarily control their respiratory rate, but you can use their respiratory rate as a marker of how hard it is for them to breathe and their degree of air hunger, if you will. Now, if you wanted to help them, besides increasing that delta P or increasing that pressure support and helping them take a bigger breath, if they need more time to exhale, we can actually manipulate 2 of those other variables we talked about earlier. 1, we can actually increase the percentage on the ETS or increase the percentage on the flow termination. And what that's going to do is it will terminate the breath earlier, right? I think the default setting on the Hamilton's like 25% of peak inspiratory flow. If you cut that back to 50%, or you increase the percent or cut back the time at which the ventilator will stop giving the breath, it will cut it off. It will cut off the positive pressure delivery at 50% of peak flow. And therefore it will reduce the total time that patient is getting positive pressure for that breath and will give them more time to exhale, if that makes sense. The other thing you can do is you can tweak the ramp a little bit. You can tweak the rise time. You can cut it back from like 200 to like 150, maybe even go as low as 100 milliseconds. I don't do this very often, but sometimes by cutting back on that rise time just ever so slightly, as that patient is starting to take that breath in and the rise time goes down, the time it takes to get to that full pressure support goes up. It'll allow them to take a breath in quicker. And then by doing that, plus going up on the percent ETS, they will get a slightly shorter breath and will give them more time to exhale. So those are 2 sort of advanced little tweaks that you can do to kind of help your patients that need that longer expiratory time or are demonstrating obstructive physiology. One additional thing that I really want to mention, and this goes for all patients, but in particular COPD patients with acute hypercapnic respiratory failure. For the love of all that is sacred, they do not have to have an oxygen saturation of 99 or 100. 88 to 92% is fine. And not only is it fine under these circumstances and very reasonable for someone who is a chronic retainer, it is actually less effective. The way their physiology works, they're actually less effective at offloading CO2 if their oxygen saturation is in the high 90s and their PaO2 is, through the roof. Why is that? Well, it's something called the Haldane effect. If the hemoglobin is super saturated with oxygen and their SAT is like 100%, that hemoglobin does not do as well in terms of like sucking up all the CO2 that gets delivered from the cells into the blood and carrying it to the lungs. If it's occupied with oxygen, it can't become carboxyhemoglobin and take that carbon dioxide out of the body and to the lungs. So it is actually helpful to keep that SAT on the lower side, 88% to 92%, because that will help them offload CO2, if that makes sense. So please, 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 especially for those COPDers, those chronic CO2 retainers, dial that FiO2 down to maintain a SAT in the low 90s, 90-ish, 88 to 92%, because that will help them offload CO2. Okay. Now we talked about we have to reevaluate these patients. Is my non-invasive ventilation working or not? Should I consider intubating this person before we get in the aircraft or not? Well, there's a couple ways to do that. One is actually the occlusive pressure. So it is on the Hamilton as P0.1. So that's the occlusion pressure 100 milliseconds after, or 0.1 seconds after the start of inspiration. And what that's basically telling the ventilator is very shortly after you start taking a breath, how hard are you working? How hard are you pulling? What kind of negative pressure are you generating or the patient generating at that point? If it's super high, that's telling you that whatever you're doing with the non-invasive, you actually have to increase their support. You have to increase their support on CPAP or BiPAP and higher levels. Specifically, if you look at a P0.1, the occlusion pressure greater than 5, or as you go up, even 7, that actually predicts pretty well relapse of respiratory failure or inadequacy of the non-invasive ventilatory support they're getting. This is not necessarily been studied in the transport environment, and like any tool, isn't the best. But if I can just cycle that screen on the Hamilton and I see that their P0.1, their occlusion pressure is 7, 8, 9 still, I know that I got some work to do with the non-invasive with the settings on CPAP or BiPAP to increase their support and help their respiratory drive come down. Another score that's very interesting, and I always take scores with a grain of salt, but this one's actually pretty good, and I like using it. If you have the data, is the HACOR score, HACOR score. And basically what it does is specifically for CPAP and BiPAP, it looks at their heart rate, respiratory rate, GCS, and pH and their P to F ratio. And it throws that into a calculation, and there's a scale that will give you the points for each of those variables. So the total points that you can get is 25. It's like the worst score, 0 being the best score. And scores above, say, 5 to 8, depending upon which literature you read, predict failure at the 1 hour mark. And that's why I really like this, because like often some of these tools are designed in the ICU to evaluate them at 6 or 12 or 24 hours. That's maybe not the most helpful thing in the transport environment, but for us, we often see them within 1 hour of initiation of positive pressure ventilation, whether the outside ED starts it or whether we start it at some point. We'll generally see them within or shortly beyond that hour mark. So this might be helpful. The disadvantage is you need a blood gas. So if you don't have a blood gas from the sending facility, or you don't have an EPOC, or you don't have an ISTAT to get a gas, you won't be able to use this score. So that's one of the limitations of it. But it actually does a pretty good job of predicting failure at about 1 hour when the scores are above 5 to 8, which means to me that you really got to evaluate that patient and take a look at them and see if you have room to go and to increase the support on non-invasive ventilation. If you're really maxed out on your CPAP or your BiPAP, and their HACOR score is still 8, 9, 10, you should really be thinking about potentially intubating that patient, or talking, at least having a conversation with the sending and receiving physician. Hey, we're kind of maxed out on BiPAP, and this patient's still really struggling. Their pH is low, the respiratory rate is high. Perhaps we should actually consider intubating them before we leave the facility. Finally, ROX index. This is best validated, I think, with seeing the response to high flow nasal cannula. However, there have been some studies looking at this tool for CPAP and BiPAP as well. And it seems to perform about the same and can be applied in this setting. Some studies actually found that it was really best at 24 hours. Other studies are finding it still works pretty well. And remember that for the ROX index, you don't need a blood gas necessarily. You can just go off their respiratory rate, their FiO2 and their SpO2, which are all readily available at the bedside for you without an iStat, Epic, or labs from the sending hospital. And at like the 1 to 2 hour mark, if their ROX index is actually lower than 6, then they have an increased rate of failure. And you should consider, do I have room to go up on the CPAP or BiPAP, or is it really time to start thinking about intubating this patient? If it's greater than 8, you're doing pretty good. You can hold the settings you got. If it's between 6-ish and 8-ish in the 5 to 7 range, I would strongly consider going up on the CPAP and BiPAP settings and increasing the support, and then looking at their SAT compared to the FiO2 they're getting and their respiratory rate, and see if their ROX index actually went up. If it went up, then we know we're moving in the right direction and we can continue to titrate things. We should point out that there's some challenges with non-invasive ventilation, some complications, challenges, things to be aware of, especially in the flight setting. It can be hard as we're moving around, the patient's moving to get a good seal. So mask fit and seal and the amount of leak is a consideration. So just make sure you're fitting the mask correctly and appropriately. Just remember that some leak is actually okay. In a lot of studies in the literature looking at chronic CPAP and BiPAP, when they're fitting people, a leak of around 24, 26% is actually pretty well tolerated. And in the acute setting, I would say anything between like 15 to 30-ish, 20 to 35-ish% leak is actually kind of expected and okay. If it's below like 10 to 15%, you may have the mask on too tight. That may not necessarily be a good thing. So keep that in mind. And if it's above the 30%, 35% leak, that's when I really try to pay attention and see what we can do to tweak the mask fitting and tighten those straps and see if we can make sure that's not leaking quite as much. Going hand in hand with that, remember we said less than 10 to 15% leak, that could be too tight. Well, that's important because skin breakdown is a very real problem. It really manifests itself, in the ED and ICU after hours or days. Rarely have I seen it become like an acute problem. I flew out to some critical access hospital. They just put a patient on BiPAP, and within 40 minutes of being on BiPAP, their skin is breaking down. But we should be cognizant of it, especially if we're transferring a patient that's been in an out small hospital ICU for 3 or 4 days on CPAP or BiPAP, and we're bringing them to a tertiary center for evaluation for something else. Difficulty communicating is a practical consideration. I'm not sure if you guys have had this, but you're trying to get a history from someone who's on CPAP or BiPAP, and you ask them a question, hey, sir, are you having chest pain? And that's like what you hear, right? And you're trying to translate what this person is saying and having to peel the BiPAP off. So just keep that in mind, of course. And then gastric distension is a very real thing. Patients can get nauseous. If you're giving them lots of positive pressure and they're trying to talk or they're swallowing air, they can get air in their stomach, which can be uncomfortable and can cause them to throw up. And then, of course, secretion clearance issues is the main reason why we try to avoid it in patients that have pneumonia. When I want them to cough stuff up, it is hard for patients to expectorate, to cough that junk out of their lungs and keep their airways clear when there's a mask on their face with constant positive pressure. So keep that in mind as well. So to review, remember those 3, I think, principles of non-invasive positive pressure ventilation. Number 1, we should be choosing it based on the pathology in front of us, not just slapping this on because we're like, oh my gosh, their SATs are low. 2, we need to be able to evaluate these patients and evaluate the effect of our intervention. And 3, we need to know how to titrate the intervention based on what's going on with the patient in front of us and how they're responding to therapies and what their underlying pathophysiology is. Remember, some of the ways that the main pathologies where there is very good evidence that you are helping someone, you are decreasing their mortality, you are decreasing the likelihood that they're going to get intubated, is COPD and CHF. The evidence is mixed and not strong evidence in the setting of asthma, but I absolutely think it's very reasonable, and lots of EMS and critical care transport protocols have this in there for asthmatics. For the whole hodgepodge of other respiratory failure, you may want to consider high-flow nasal cannula or some other delivery system before CPAP or BiPAP, and only using it as sort of a last resort. We talked about the 2 ways of titrating CPAP and BiPAP, more specifically BiPAP, for obstructive and congestive pathology. And then we talked about evaluating how patients are doing and if we need to increase support or actually invasively manage their ventilation by intubating them. And those tools are the P0.1, the occlusive pressure, the Hackor score, and the ROX index. And finally, we talked about some of those complications. So that is the jiu-jitsu of non-invasive ventilation in a nutshell. Thank you guys so much. Hope you enjoyed the episode, and we'll talk to you soon. Take care. Stay safe out there.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.